Hello and good evening, everyone. It's great to be back here once again with all of you. And I'm very happy to have you, Dr. Luca Gianaroli, back with us because I think it's more or less a year you've been here with us. So it's a pleasure to have you back here. And I'm very happy that you agreed to present this specific topic with us tonight. Hi, and how are you tonight?
Very well, thank you.
Thank you so much indeed. And so just in case you are not yet familiar with Dr. Luca Gianaroli, let me just mention that he's the scientific director of SISMER, which is Italian Society for the Study of Reproductive Medicine, located in Bologna, in Italy, of course. And Dr. Luca Gianaroli will be talking tonight about PGT-SR. And I am very happy that, of course, you will present this topic. We've already discussed PGT-A, PGT-M, as you know, and tonight we will discuss PGT-SR. And just remember, we will start with the presentation, as always, and afterwards it will be your time for your questions. So just remember to type those in the chat section. Dr. Gianaroli will definitely help you out with them. And as you know, my Aviofensis is now part of European Fertility Society, and we are very, very proud to be here every single day from Monday to Friday and provide you with those topics, give you the opportunity to meet top fertility experts, but also give you the chance to ask your questions and get some answers for sure as well. And that will be it from me at this point. Dr. Luca, are you ready to start with your presentation?
Sure, whenever you like. You just show the first slide?
Yes, of course, right here. Thank you so much.
Good. So good evening, everybody. The presentation of tonight is a special presentation because, in fact, the general population has the risk of having a structural rearrangement of chromosomes around 3, 4, 5 every 1,000. But in the infertility population, this percentage, it goes down to 5, 6%. So it's not so unusual that sometimes, mainly in those centers in which the chromosomal analysis is not performed before starting the treatment, you have couples that produce embryos, and these embryos either they don't develop properly, either once they develop properly they do not implant, either if they implant they miscarry after a few days, or they just produce a rise of beta ACG, showing that there has been an implantation, but the pregnancy is not viable. When you check these patients, sometimes you find chromosomal abnormalities in terms of structural rearrangement. So that's the reason why PGT can also be used to check if your embryos are chromosomally normal from the point of view of the structural rearrangement. What does it mean? Well, first of all, when we test for structural rearrangement, we have a procedure that aims at detecting a specific pathology, chromosomal abnormalities involving a change in the structure of the native chromosome that may generate gametes with displacement of genetic material, for instance, translocation. So these anomalies, and I go back to this, subsequently can be transferred to the deriving embryo. Patients that are carrier of translocations or other rearrangement, they are more prone to be infertile, as I mentioned before, to generate pregnancies that they miscarriage, or to have some hereditary disorder. Let's first of all talk about the translocation. What is a translocation? First of all, we have two different types of translocation. The first one is called Robertsonian translocation, and in fact occur when a part of a chromosome becomes attached to another. Generally speaking, the majority, if not all, the Robertsonian translocation involves these chromosomes, 13, 14, 15, 21, and 22. They are the most common structural chromosome abnormalities in humans. And as I was mentioning to you, one individual out of 1,000 is a carrier of Robertsonian translocation. But again, in the infertile population, this 1 out of 1,000 can go down to 1 out of 100. Then we have the reciprocal translocation. The reciprocal translocation are those translocations in which or where they occur when there is a detached fragment of two different chromosomes that are switched. And here you find an example here. For instance, this part of the chromosome is attached here, and that is what you have at the end. So there is a change in the position of genetic material. Then we have inversions, and inversion means that occur when a segment of a chromosome is reversed end to end. We could have microdeletion, that means that there are small fragments of the genetic material that just are lost during the meiosis, or we can have duplication. Duplication occurs when new genetic material is generated during the meiosis. So these are the rearrangements that I would like to talk about today. Translocation can be balanced. So that means that they occur when the chromosome abnormality does not imply a gain or a loss of the genetic material. Or they can be unbalanced, so they occur when the chromosome abnormality does cause a gain or a loss of the genetic material. Unbalanced translocation have more severe consequences if you compare this to the balanced translocation. And the severity of the translocation depends on the chromosomes that are involved and the number of genes that are involved. So if we look at the clinical history, the medical history of the patients, and they have a story of infertility, of recurrent miscarriage, or growth retardation during a previous pregnancy, the only test that can help you is the karyotype. Our group, personally, and for all our clinicians, is mandatory to perform karyotype in the couple. That is only a blood sample before we start any IVF treatment. And the reason is very simple. It's quite a cheap exam. It can be done any time of the cycle, and it lasts forever. So it's like a blood group. Once that you have it, it will not change for the rest of your life. And again, you can find abnormalities that can guide or that can change the course of your treatment. Take into consideration that sometimes some translocation, for instance, like the Robertsonian translocation, they can also be involved in other pathology. So a Robertsonian translocation can also generate affected individuals, affected like Edwards syndrome, Down syndrome, or other syndromes. If the carrier is a carrier of reciprocal translocation, if the translocation is unbalanced, then mental retardation or physical disability can occur in the offspring. When we have inversion, microdeletion, or duplication, again, other pathologies, some of them are listed there, and they deal with the epigenetic disorders, they can occur. So, by the way, a normal carrier of a translocation can generate an offspring with severe disease. So it's better to know if the patients are carrier of either Robertsonian or reciprocal translocation, or carrier of inversion, microdeletion, or duplication. By the way, some translocation can cause infertility. For instance, we will see the data about this. Male carriers of Robertsonian translocation are more likely to suffer from infertility because they frequently have abnormal semen parameters. So to have a multidisciplinary approach that include, of course, geneticists, andrologist, embryologist, is the key to win the problem of infertility in these patients. You can see, for instance, here, a male in which the chromosomal analysis is a 45XY with a Robertsonian translocation. So there is a translocation between chromosome 13 and 14, and this translocation occurs in the fragment Q of the chromosomes. So this is what you find in the chromosomal analysis once that you do it, if you are a carrier of a translocation. We know that the reciprocal translocation, even if they are balanced, they increase the risk of recurrent miscarriage. In fact, there is quite a large percentage of couples that suffer from recurrent miscarriage, at least 1 out of 20, in which at least one of the partners was a carrier of a balanced translocation. So they have no symptoms. They don't know that they are carriers. Balanced translocation also, not only involve specific chromosomes, but some of these chromosomes are more likely to cause miscarriage than others. So it's important to know which is the translocated chromosome. So what does it mean? That the flow chart is that once that you do the preliminary test, including if it's needed for the treatment, a setup that check that our machinery, our genetic laboratory is able to detect the translocation, then ovarian simulation can be done and oocyte recovery will follow. If the number of oocytes is not large enough, more than one simulation can be performed, even back-to-back, the so-called dual simulation. Then in vitro fertilization is done, or X is done, biopsy and then cryopreservation, and then the chromosomal analysis is performed. It's possible, if some translocations are very severe, like some reciprocal translocations, that there are no embryos enough that are generated to have at least one embryo to transfer. So, in fact, we will see that according to the translocation and according to the carrier, if it's a male or a female, the number of embryos that should be discharged, because either they don't implant, either if they implant they miscarriage, is extremely high. So what we need is a blood sample from the couple, also a buccal swab, and so we can make the analysis of the potential parents, and once the analysis is performed and we know that we are able to detect the translocation or the inversion, we do the biopsy. It could be at the trophectoderm cells stage, could be also the blastocellic fluid from a blastocyst. We extract the DNA, we amplify many times the DNA, so we have a reasonable amount of DNA able to be checked by the most sophisticated sequencer, and then we do the chromosomal analysis, either with NGS, as I was mentioning, either with array CGH. The end of the day is that generally talking, in terms of routine, once the embryo reaches the blastocyst stage, so after 5-6 days after insemination, we take a sample of trophectoderm cells. The trophectoderm cells have the same chromosomal status of the embryo from which they are collected. So if the embryo will implant, they will give rise to placenta. The advantage of doing trophectoderm biopsy is that the embryo itself is not affected. The disadvantage is that since we don't have an answer in real time, we need to cryopreserve the embryo and to do the transfer the months after. We can remove the fluid from the blastocyst, so we know that the DNA is contained in the blastocellic fluid, and that reflects the chromosomal status of the whole embryo. The advantage is that the minimally invasive technique, which does not affect the embryo and does not affect the developmental potential, and can be complementary to the trophectoderm cell analysis. Even here, also for this technique, embryo cryopreservation is necessary. And this is what the computer and the sophisticated algorithm says to us, in the first part of the slide on the left, you see that the genetic material, and these are the chromosomes, 1, 2, 3, 4, and so on, until the chromosomes, the sex chromosomes, X and Y. You see that in this case, all the embryo produce in each chromosome the same amount of DNA. So there is no loss or gain of genetic material. So this is a transferable embryo. What we see here is that there is a loss of genetic material in this chromosome. So this embryo is not transferable because part of the chromosome is lost. Here we have in one chromosome one extra amount of DNA in chromosome 2, and here we have a loss, a partial loss of another chromosome, that is chromosome 17. So again, also this embryo is not transferable. So all in all, what you have at the end of the day is a computer analysis of the amount of DNA that we have generated in the specific embryo that we want either to transfer or not to transfer. The accuracy of this technique is very high, can reach 98, 99%. It should be advised the pregnant patients that if we want also to check out that 1 or 2% of potential misdiagnosis in case of pregnancy, we should perform prenatal testing, an IPT, that is non-invasive prenatal test. And if again also an IPT shows some doubt, then go for invasive diagnosis, either with chorionic VD sampling, either with amniocentesis. Let me show to you what does it mean to be translocated. This slide seems to be complicated, but it's only to say that in our work, we went through 2001 couples in which one of the two partners had a reciprocal translocation. So they were a healthy carrier of translocation, either the male or the female. Among these 201 couples, 109 couples had previous natural pregnancies, while the remaining 92 had no natural conception. So these 109 couples generated 273 pregnancies. So they look like being apparently fertile. But what's happened to these 273 pregnancies? Well, 80% of them miscarriage. Another 13% went through termination of pregnancy because the fetus were seriously abnormal. The remaining generated 21 live births. That is only 7% of the total amount of pregnancies that these 109 couples generated naturally without any assisted conception. But when we look at these 21 individuals, you can see that only 5 had normal karyotype, 7 had a balanced karyotype, and 9 had severe malformation. That means that out of these 273 pregnancies, only 12 healthy babies have been generated. That is 4.4, having one of the two parents being a carrier of a reciprocal translocation. When we look at the remaining translocation, the Robertsonian, again, this is our data, 105 couples, among them 43 couples had previous natural pregnancies, while the remaining 62 did not conceive. These 43 couples generated 94 pregnancies, and again, if we look how they finished, we have again 80% that finished in a miscarriage, terminated in a miscarriage. Another 10% ended with a therapeutic termination of pregnancy. So only 10 live births have occurred out of 94 initiated pregnancies. And among these 10 live births, only 6 had normal karyotype. 2 were balanced and 2 were unbalanced with different malformation. That means out of 94, only 8 healthy children were born, 8.5%. Why these numbers? Because when we do PGT for structural rearrangement, this is what we find. Have a look to these carriers. They are male carriers of Robertsonian translocations. First of all, if we do the test on individual sperm, and this is the number that we have tested on these patients, 1 sperm out of 5 or out of 6 is unbalanced. When you choose your sperm randomly and you inject into an egg, these are the results that you find. Only 32% of the embryos are suitable for transfer. The other are either unbalanced, either aneuploidy, either a combination of unbalanced and aneuploidy. So these 7 embryos out of 10, if transferred, they would give rise either to nothing, either to a miscarriage, either to a potential abortion, either to a malformation. And this is for men being carrier of Robertsonian translocation. If the man is a carrier of a reciprocal translocation, again, you see that among the sperm tested in these individuals, 63% of the sperm were unbalanced. That means that we inject randomly spermatozoa inside a egg. Only 1 embryo out of 10 or 13 out of 100 are transferable embryos. And that's because the remaining are either unbalanced and aneuploid, either aneuploid. And this is when the male partner is a carrier of translocation. What's happened if is a female partner to be a carrier of a translocation? Here we are, ladies with a carrier of a translocation that is Robertsonian. Again, unluckily, you now already know the green color. Only 1 embryo out of 5 is transferable. And if the patient is a carrier of a reciprocal translocation, again, you see that only 10% of the embryos are chromosomally normal. So there is only 1 embryo out of 10 that is transferable. In fact, when we look at the data, and I just choose our own data because we know them better, if you look at this section, that is the PGT for structural rearrangement, you see that out of 169 patients that have been introduced in this program, either because male or female were translocated, you see that not all these patients had an embryo transfer because there were no normal embryos. The number of pregnancies is this one, that imply 40%, 38% of clinical pregnancy per embryo transfer. And of course, if you look at the number of babies that are born for the total number of cycles transferred, what you have is that 1 individual or 1 couple out of 4 delivery after 1, maximum 2 transfer. So here the concept is that we need more embryo, as many embryos as possible, to transfer to the patient 1 single embryo at a time, different times or many times as far as the pregnancy is not reached. These are the numbers, and this is what has happened in our experience when structural rearrangement occur in one of the 2 partners that are looking for babies. I like to close here to leave some time to some question if it's needed.
Wonderful. Thank you so much. It's definitely interesting what you have presented. Thank you so much for providing all the data. This is definitely useful for all the patients, I am sure. And now it is time for the questions. So, of course, there is one question already. So if you haven't asked your question, you know what to do. Type those in and let's start our Q&A session. Okay, Dr. Gianaroli?
Yeah.
Perfect. So the first question is from Emma. Are the embryos harmed by freezing and thawing?
No, Emma, even if there is a variability that's changed from patient to patient, the survival rate and the viability rate of a frozen thawed embryos after biopsy, it varies between 98 to 100% of viability. So the risk of losing an embryo is extremely limited as far as the right technique is used, and in this case, talk about vitrification technique.
Thank you so much for the very first question, Emma. Of course, Dr. Gianaroli, for your answer to this question. Next question we got from Bubble. Do translocations in sperm or oocyte have an effect on fertilization rate or embryo development during IVF-ICSI?
Not on fertilization, because most of the time using ICSI, you just force fertilization. The problem is that in some translocation, these embryos have no energy enough if they are generated by unbalanced gametes. They have no enough resources to develop normally. So these embryos, they do not develop properly. So no for fertilization, potentially yes for embryo development.
And wonderful. Again, thank you so much for your question. And more questions are coming in. I can see there are people typing. So let's have a look. Emma has added one more question. Is it true that you need to recruit more eggs when planning treatment with PGT-SR or PGT-M, and why?
Well, for a very simple reason, because you know in advance that you will have a percentage of these eggs that even if fertilized or even if they develop an embryo, they will not be transferable. So you need more eggs to have more embryos to choose from a larger basket of embryos, those that will be suitable for transfer.
And that makes perfect sense. Again, thank you so much for explaining this one as well. And Sebastian has added one more question. So what do you do when the trophectoderm biopsy reveals mosaicism? Do you do the transfer?
I think that this topic has been already discussed in one of the previous seminar, but all in all, it's quite a complicated question because it depends on the type of mosaicism, it depends on the percentage of mosaicism. What is interesting is that if you use some technique, actually you don't see the mosaicism. You only see if they are euploid or aneuploid. So they are black and white. If you use more sophisticated techniques, then you can see the mosaicism, and then there is a sort of degree of risk that you can take in transferring embryos that are mosaics according to the percentage and according to the chromosomes that are involved.
Once again, huge thank you for yet another interesting question. And of course, you are right. We were talking about this. And of course, when we finish, you will be redirected to the profile, Dr. Gianaroli's profile. So you will be able to have a look at the previous webinars with him, and you can have a look at it and check some of the presentations and of course, Q&A as well. And let's have a look. I need to, yeah, there is one more question here. So after how many failed IVF cycles would you recommend sperm and or egg donation?
It depends. What do you mean for fail? If you mean no embryo development, so no embryo transfer, I would not go, if you are a poor responder, over 2 cycles. If you are a poor responder, you can wait also for a 3rd cycle. If for you the failure means a biochemical pregnancy or a miscarriage, then you need anyway not to stop IVF, but to go for PGT, for aneuploidy. Of course, this implies that first you have to have performed in both partners the chromosomal analysis.
All right, perfect. Thank you so much. Yet another question bubble, and of course, for your help with that. I need to wait a bit, okay? At least at the moment, I don't see more questions, but of course, go ahead, type those in. If you have any left, just go ahead and do it. We need to wait a bit. I just want to make sure that you have asked all your questions, of course. So let's give it a minute and see if we have more questions, of course, okay? If not, we will be finishing. So don't hesitate.
Okay.
Use this opportunity to ask Dr. Gianaroli some questions. And yeah, someone is typing, okay, Dr. Gianaroli. So we need a minute to see whether it's a thank you or a question. So it can take some time sometimes. Okay, let's have a look. Yes, it is a thank you. So I guess we will be slowly finishing with the webinar, but I would like you to have a look. Thanks for your presentation, answering my questions, and we are happy that you were able to get some answers, Babel, for sure. And if you don't have any more questions, we will be finishing. But Dr. Gianaroli, before I let you go, is there anything you would like to add?
Only one thing. All of you deserve a personalized treatment as much as possible. So once that you fail pregnancy after 1 or 2 embryo transfer, look and ask for a personalized treatment, because we don't want you to be treated and retreated without any success. At these days, pregnancy rates are very high in almost all the centers. So if you fail pregnancy, there must be a reason. If you fail twice a pregnancy, there must be an important reason. If you fail pregnancy after 3 embryo transfer, we need to find the reason why you don't get pregnant. And maybe chromosomal rearrangement is part of your problem.
Perfect summary again. Thank you so much for again reminding everyone why definitely it should be done and when. And we will be finishing for tonight. There's one more thank you for you. So thank you so much from Emma for answering my questions. And well, thank you everyone for joining us tonight, for your questions. And of course, Dr. Gianaroli, it's always great to have you here. And as always, you've been very clear with answering all the questions, but also with the presentation you have provided. So it's great to have you back, that's for sure. So it's been definitely a weird year that we had, and it's now amazing to see you back here. And I do hope that we will have more events with you coming up pretty much soon. Thank you as always. And of course, remember, it has been recorded. You will be able to have a look at this. It will be available tomorrow on our site, myivfanswers.com. As you know, there are over 300 IVF webinars already, so there are plenty of topics you can have a look at. And there are like 3 more webinars. There were 3 more webinars with Dr. Gianaroli, so don't hesitate to have a look at them as well. And again, Dr. Gianaroli, it's been a pleasure. Thank you so much, and have a lovely evening. Thank you.
Bye-bye.
Take care, everyone. Bye.
Bye.